Good morning, everyone, and welcome to our inaugural talk on maternal child health disparities. We are very excited to have everyone here today. We are going to give everyone a moment to just get logged in. I know it takes a little bit for Zoom to get set up and for individuals to get into the room and to get their audio set up. And so we'll just pause for a moment and we will begin shortly. Okay, it appears that we've got a critical mass here. We are, again, very excited to host today's talk. We have about 300 people who have registered for today's talk. And as you can see within the chat, people are very excited to see you as well. Before we get started, I just wanted to take a moment to thank the Department of Human Services for sponsoring this event through the state of Minnesota. And a big thanks to Ruthie Dallas and all of her leadership in terms of making this happen. She has been a huge champion of health equity within the state of Minnesota and with DHS for a number of years. And this really comes as a result of the long-term partnership that Wayside Recovery Center has had with the Department of Human Services. And we are excited to not only to start this conversation, but to also be thinking about the ways that we can be transforming the way that we provide our services to really meet the needs of all Minnesotans. So we're going to get started because we want to ensure that you all have as much time with Dr. Jones as possible today. And we want to start with an introduction with Dr. Chomolo, who is the co-founder of the Minnesota Doctors for Health Equity. He's also the Medicaid Medical Director for the Minnesota Department of Human Services and adjunct faculty at the University of Minnesota Medical School. He's also currently leading up the Minnesota Department of Health's COVID-19 vaccine equity team. And he too is a longtime champion of equity within the state of Minnesota. And we are so pleased to have you in all of the different leadership positions that you are in within the state, with all the work that you're doing to ensure that we're building a state that works well for everyone. So Dr. Chomolo, so great to see you this morning, and the floor is yours.
Thank you, Representative Richardson, and so excited to be here. As I was joking with folks before, really excited to be Dr. Jones' cold open. And so I think it's helpful to kind of set the stage and start with maybe some definitions. I know Dr. Jones will cover several, but what I have found is when we use words like health equity, often that can mean different things to different people. And so I think helpful to start with, well, what are we talking about when we say health equity? And it's really the opportunity to reach one's full health and potential. And so if you don't have equal opportunity, you therefore get inequity. And inequity is really what drives disparities. And so if we're talking about maternal and child health disparities, we are talking about inequities. And it's really important to look at how opportunity for health is then structured. And in the US and in Minnesota, you cannot seriously address structural inequity without addressing structural racism, and how policies intended to benefit one community did so at the cost of another, based off of skin color. And so one distinct way to see how this is played out in Minnesota is through redlining and racial covenants and housing segregation. And so in the 1930s, the Federal Housing Administration devised a classification scheme for urban residential properties to make the process more accessible for new home buyers. The system classified homes and neighborhoods into 4 tiers, ranging from the most desirable and likely to retain their value, which were green on those maps, to those whose values were expected to or were already in decline, and those were red. And those lines also fell along very intentionally along the lines of the racial makeup of those neighborhoods. And in addition, in Minnesota and many other places, but notable in Minnesota and the Twin Cities, there were racial covenants placed on the deeds of houses that legally prohibited Black, Indigenous, Jewish, and other people of certain racial or ethnic heritages from even owning homes in those green areas. And so if you look at maps from the 1940s and you look at maps today, those redlined areas track right along with how the Twin Cities remains racially segregated. And with that came less wealth through homeownership due to undervaluation of red areas and predatory practices by banks. There was less wealth due to less access to jobs with benefits like pensions and health insurance. And since schools are largely funded by the neighborhoods in which they reside, there was less access to the same amount of education and resources. And so this cycle of inequity is why we see such stark disparities in Minnesota today. And in fact, the median Black family in the Twin Cities area earns roughly $38,000 a year, which is less than half of the median white family income of roughly $84,000 a year. And this income inequality gap is one of the largest in the nation, with only nearby Milwaukee being worse. And if you look at the state of Minnesota as a whole, it has the second biggest income inequality gap between Black and white Minnesotans in the entire nation. Only the District of Columbia is worse. And so to address these disparities, we need to address the underlying inequities, and we need to lead with a lens of both health and racial equity. And the good news is we all have the power to do just that. And so when we were starting Minnesota Doctors for Health Equity, we were really trying to structure our work through that lens of health and racial equity, looking at 4 different levers that us as members and as institutions can look at: personal work within our organizations or professional organizations, and with engaging government through advocacy. And personal levers really start with learning more about how you yourself may have benefited or been at a disadvantage because of structural racism, and then sharing and teaching that with those around you, thinking about what individual steps you can do with the dollars you can control, with the time you can control. Then the work lever is looking at the places that you work and what are the ways that within your own work settings you can, again, help engage those systems to look and face the structural inequity and structural racism that is there, and move forward to becoming more anti-racist. The same thing with organizations, professional organizations. And so whether that is a professional organization for your healthcare or other professional organizations related to your community, how can you really engage and have a systematic look at how structural inequity, structural racism is working? And then in government, advocacy is not just, going to the Capitol. It's talking to your city council member, it's talking to your state representative or your state senator, but really talking amongst and organizing around how you can really inform the decisions that are being discussed and how they have an impact on health and opportunity for us all. And so through this lens, when I hear that Indigenous Minnesotans are 7 times as likely to die from a drug overdose as white Minnesotans, and Black Minnesotans are 2 times as likely to die from a drug overdose as white Minnesotans, I look to work on inequities in housing and education, for example, but also realize that studies have shown that people of color are less likely to be started on and maintain on medication for opioid use disorder, so that I as a clinician have to work on doing education myself and my colleagues around what is driving that disparity as well. And this is really a lifelong journey. And so I'm glad you're all here today, no matter where on that journey you are. My path took a distinct turn almost 5 years ago when Philando Castile was murdered. And I'm ashamed to admit it took that to move from this idea of just identifying and looking at disparities to really looking at the structural inequity and racism. But I really just helped me discover the brilliant work of Dr. Camara Jones. And she has inspired much of the work of me and my Minnesota Doctors for Health Equity co-founders ever since our inception. And so I'm so incredibly honored to play a small part, as I said, as a cold open, in what I know will be a powerful talk, and quite possibly, like it was for me when I first heard the Gardener's Tale allegory, a life and career changing moment. So I will turn it back to Representative Richardson and really look forward to this morning.
Thank you, Dr. Tromolo, for being here this morning and for that very inspiring welcome. So now to our speaker of the day, Dr. Jones. She's a past president of the American Public Health Association and was a 2019-2020 Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University. She's taught at Harvard, the School of Public Health, the Morehouse School of Medicine, and Rollins School of Public Health, and has served as a medical officer at the Centers for Disease Control and Prevention. And this is just a small snapshot of the things that Dr. Jones has accomplished. She has an amazing resume, and we are so grateful to be able to be in your presence today and to be able to hear from you. I read your work about the Gardener's Tale when I was in college myself, and have been inspired by your work for many years, including the work that you have done around maternal child health disparities, as well, with that very compelling public television documentary that you were a part of. So with that, Dr. Jones, the floor is yours.
Thank you. Thank you so much, Representative Richardson. Thank you, Dr. Chomolo. Thank you for being who you are and filling up our minds and all with information. And I don't know what happened, because you guys saw me at the beginning and all of a sudden I was out and they wouldn't let me back in. But we will have this communication together. We will have these discussions. The work will go on despite the barriers. We must persist. So I would like to start sharing my screen. And so you guys need to enable me again to share my screen. So that's Dana. Like, we were all set up and everything, but this is how life is, right? But if you are focused and you just keep on going, you know, we will make it. We will go boom on the point. So let me see.
And you should be able to share once.
Now I am. Okay. Thanks. So, and let me put this in presentation mode. So I'm delighted to be able to actually stimulate what I consider to be a conversation among us on addressing racism as a public health crisis. And I was the president of the American Public Health Association 5 years ago in 2016. And I used that platform to launch our association and as many other communities and organizations and all of our 54 state affiliates and everybody on a national campaign against racism with 3 tasks. The first being to name racism, equipping people with tools and the fortitude, the strength, the focus to say the whole word, because it is important to name a problem if you're going to start solving it. But we must go beyond simply naming racism and move to action. So the second of the 3 tasks is to ask the question, how is racism operating here in my child's daycare, in my community, in this workplace, in this city, in this state, in the nation, in the world, identifying levers for intervention, targets for action. And then the third task, once you have a little bit of focus about, you know, what you and your collective are going to work on, is to organize and strategize to act, because collective action is going to be what protects us and propels us and inspires us and informs us. Collective action is going to be the way that we promote a sustained effort across place and across generations. Now, that national campaign against racism that I launched for our little organization, you know, American Public Health Association, actually was the spark for at least the first of what are now 208 declarations that racism is a public health crisis, declarations by city councils and county commissions and at the state level as well. So the first, I'm going to take a little credit because I was told Lillian Payne in 2018, 2 years after I was president at the Wisconsin Public Health Association, actually crafted a declaration for that Public Health Association. And in May of 2019, then the Milwaukee County executive adopted that declaration, and that became the first in Wisconsin. But now you're going to look month by month how ideas spread, and then you're going to see the impact of national events. So, you know, we started recognizing COVID in April, and in May, look what's happened. And then Mr. George Floyd was murdered, you know, and then so you saw what happened in June. And month by month, more and more states are have jurisdictions, at least one city council or one county commission, or 11 now at the state level that have made formal declarations that racism is a public health crisis, 208 jurisdictions across 37 states. This is great, right? It is great because each of these jurisdictions is placing a stake in the sand. And as you know, Representative Richardson brought to the Minnesota State Legislature your declaration. That's why Minnesota is written in all caps. Those 7 states that are written in all caps have something that was done, a governor's statement, a state legislative act, something done at the state level. The numbers after each state represent the number of jurisdictions in that state that have made a formal declaration. California is leading at 31, but then Ohio is in a close second at 27, and then Connecticut at 22, and the like. This is important because, yes, people are putting a stake in the sand. They're saying, hold us accountable, public, for addressing racism. Some of the declarations have further action steps, which is important because just saying a thing is one thing. It's important, it's necessary, it's essential. It's essential to name a problem if we're going to address it, but it's insufficient. Necessary, but not enough. Necessary, but insufficient. So I am going, the rest of our conversation and comments today are going to be in 3 sections. First of all, framing the work. Why is it that people are saying racism is a public health crisis? Because they could say racism is an educational crisis, which it is, or a housing crisis, which it is, or an environmental crisis, or a justice and a criminal, criminal system. It's not a criminal legal system crisis. Yes, it is. But these declarations have focused on health, partly because our bodies is how all of these other things, these opportunities or lack thereof, all of these assaults or the protections are finally felt in the individual. But it's also true that when we think about health interventions, we need to think about racism. So the first thing, I'm going to give you a little cartoon animation. Then we're going to have a pause for discussion. Just to, how are you feeling that animation? Did it make sense? Did it equip you to do something different? Then the second section of our 3-part talk is going to be about naming racism. And here I'm going to share with you 2 of my allegories, my dual reality restaurant saga and my levels of racism, A Gardener's Tale, that Representative Richardson said she read when she was in college. So that is how, well, I don't know how long ago she was in college, could have been last year. But anyway, that story has been published for 21 years. So I'm going to bookend that with definitions and all of that. Another pause for discussion. And then finally, we're going to get to the most urgent part, which is moving to action. So I will share with you my latest allegory that I have not yet published yet, Cement Dust in Our Lungs. And then we'll talk about equity and barriers to achieving equity and end up with what can we do today? And then as icing on the cake, I'm going to review everything that we had shared with what I'm now calling my anti-racism primer review by the numbers. So that's the roadmap for the next, now I know, some of my time was trying to get back to you all, but for the next hour and a half, let's say, this is what we're going to be doing. So part 1, levels of health intervention. This is my cliff analogy. Hold on, let's go. Whoops, boom. Somebody just fell off of a cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff face, so if we were concerned about population health, public health, community health, we might well ask ourselves, what should we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody's going to say, I know, let's put a net halfway down. That way, even if somebody falls, they can get caught up in the net before they get crunched up at the bottom of the cliff. And that is an excellent, excellent idea. Although you do recognize that nets do have holes in them. So some people might fall through the cracks, but never mind that. We could even make that a trampoline halfway down the cliff. No holes in a trampoline. But even if there were a trampoline halfway down that cliff, we might find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So What else could we put in place as a health intervention? Well, clearly we need a fence at the edge of the cliff to keep people from falling in the first place. But that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else can we do as a health intervention? Well, we can move the population away from the edge of the cliff. So let me label these interventions that I have illustrated so far, where the ambulance at the bottom of the cliff represents acute medical care, and what we on the public health side of things describe as tertiary prevention. So, 3 levels of prevention that we talk about in public health: primary, secondary, tertiary, where tertiary prevention is preventing the complications from disease that's already manifest. For example, preventing an amputation from diabetes, let's say, or preventing the need for hospitalization with a COVID-19 diagnosis, right? So now that net or trampoline halfway down, these represent our safety net programs and secondary prevention. Safety net programs often in our social services. Secondary prevention being early detection, screening, right? Which can be in clinical settings, community settings, and the like. Primary prevention is what that fence represents, keeping bad things from happening in the first place, like a COVID-19 vaccine, or like a policy, like a tobacco 21 policy, making it more difficult for young people to have easy access to tobacco products. Moving the population away from the edge of the cliff is what people describe as addressing the social determinants of health, those determinants of health and illness that are outside of the individual, beyond our individual genes and beyond our individual behaviors. And in fact, these social determinants of health are the context of our lives, right? They include our individual context, so our individual education, occupation, income, wealth. So addressing poverty is a very important way of moving the population away from the edge of the cliff. They also include neighborhood context. Is there a job in your neighborhood? And if there's not a job, can you get to one? What is the quality of the housing in your neighborhood? The quality of the schools? Can you get fresh fruits and vegetables in your neighborhood? What are the police doing in your neighborhood? Are you afraid for yourself or for your kinfolk, right? And so addressing adverse neighborhood conditions is another important way of moving the population away from the edge of the cliff. So we could illustrate, we're talking about maternal and child health outcomes. Let's think about infant mortality as an outcome and see what these different interventions might be. So the numbers of our babies dying before their first birthday, that's the infant mortality rate. Well, the ambulance to lower infant mortality rate might be our neonatal intensive care units in the hospitals, right? So babies born early, and then we're just trying to protect them, keep them alive. The net or trampoline halfway down might actually be prenatal care, where you're going in for appointments to be screened to make sure that your health is still good. So that's like early detection in case blood pressure seems high, or it looks like you're getting diabetic, or you have too much protein in your urine, that kind of thing. The fence at the edge of the cliff, primary prevention, could include excellent maternal nutrition. So our women, infants, and children programs, for example, or it could be prenatal parenting circles or the like. Moving the population away from the edge of the cliff could be a living wage, so that pregnant people don't find themselves in poverty, or it could be excellent educational opportunities so that young women and girls don't feel that their main option in life is to have a baby too soon, right? So you see, you can illustrate, you can see that we need some of all of it. We need the ambulances and nets and the fences. We need to move the population away from the edge of the cliff. We could go into a community and say, how should we be spending our health resources? How much on each of these things? It's a useful diagram, right? But as far as I've shared it with you so far, it has a huge fatal flaw. And the huge fatal flaw is that it does not yet equip us to talk about how health disparities arise, the differences in populations in terms of infant mortality rate and the like. So I want you to keep this cliff, as useful as it is, but with this huge fatal flaw in the back of your mind for a moment. We're going to shift gears to talk about how health disparities arise on 3 levels, and then we'll come back to the cliff. So there are lots of different axes along which health disparities arise. So they arise by, race, ethnicity, but by zip code, by language, social class, all that. But especially when we talk about racial, ethnic health disparities, we unfortunately have lots and lots and lots of evidence about differences in the quality of care received within the healthcare system. So the Institute of Medicine, which is now called the National Academy of Medicine, but way back in 2002, 2003, did a review pulling together what were then, oh, my tongue is all twisted, but pulling together what were then hundreds of studies documenting differences in the quality of care for people who are in the same healthcare system. So everybody in the VA system, or everybody covered by Medicare or Medicaid, right? There were studies that said there were well-documented differences in how vigorously your chest pain might be investigated or treated, depending on your race, or how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity or your race. So that report in 2003, that unequal treatment report, sent shockwaves throughout the medical industry, right? And people were like, oh, well, I try to treat all of my patients the same. Well, trying and what you do are two different things. Intent is different from impact. But even that Institute of Medicine panel that wrote that report said there's a very important thing. We're only considering people who already are in the healthcare system, but there are a lot of people who can't even access the healthcare system in the first place. That is a second level at which health disparities arise. But I'm hoping that everybody listening to me right now recognizes that health is not created within the health sector. So there's a third level at which health disparities arise, which are in the differences in the conditions of our lives. Differences in our life opportunities, exposure, stresses that are making some individuals and communities sicker than others in the first place. And if we wanted to think about these three levels at which health disparities arise, differences in quality of care, differences in access to care, differences in underlying exposures and opportunities, and we want to say, well, what's the relationship between them? We could actually draw it as a pyramid, or better yet, understand it as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then very often the same people who have been made sicker are frustrated because of limited access to the healthcare system. And then sometimes even the lucky ones who get into the healthcare system are further injured because of differences in quality of care. So now, remembering these three levels at which health disparities arise, we are going back to the cliff. But now we're going to recognize we're not dealing with a flat two-dimensional cliff. We are actually dealing with a three-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all. Maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now let me label our three-dimensional cliff with how health disparities arise, where the differences in quality of care are represented by an ambulance that's there but has a flat tire. So it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. And differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there is a whole new set of questions that arise. The first and most important question perhaps being, how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back there in a way and the greenies being pushed closer to the edge? And when we start asking and addressing those questions, we're doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like. When we start talking about systems of power that can differentially distribute resources and populations, we are now addressing the social determinants of equity or inequity, which include racism, sexism, heterosexism, economic systems like capitalism and the like. And actually with this cliff, I have distilled, if you will, 3 different dimensions of health intervention. So if you go back to your junior high or high school geometry, 1 dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along that line at the edge of the cliff is where we can display all of our health services, our ambulance net fence right there, curative and preventive health services. This is what most people think of when they hear the word health. In fact, if somebody says the word health, if I say the word health, somebody else is going to complete that thought for me and go immediately to healthcare and health services. They're immediately going to the edge of the cliff. And our Affordable Care Act is an edge of the cliff conversation. And our efforts to try to get to universal access to high quality healthcare will still be an edge of the cliff conversation. Now we need to try to get to universal access to high quality healthcare and join the rest of the civilized world and you know, whatever. The most of all of the world has some kind of guarantee of health or health care, right? We need that because that is how a civilized society values all of its people equally. But that in and of itself is not going to result in large and sustained improvements in health outcomes or the elimination of health disparities, because you can overwhelm any system if you're pushed up against the edge of it, which means that we must move into that 2nd dimension that I can display along a flat plane. We have to be addressing the social determinants of health, addressing poverty, adverse neighborhood conditions, and the like. If we want to have large and sustained improvements in health outcomes, we have to move the population away from the edge of the cliff. But here's the trick. If we're about moving the population away from the edge of the cliff without recognizing that we're really dealing with a 3-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. We're seeing that even with COVID-19. So now there's a vaccine, but then if the vaccine isn't getting to all of the different populations, then now the health disparities in terms of the who's getting COVID and who's not, because more people who are away from the cliff are protected, the health disparities are going to get worse. You know, I'm kind of, going off a little bit off of what I was going to share with you, but there was a fear when people who had lived through the HIV/AIDS epidemic saw COVID. They were like, oh no, we have to make sure that when there's a cure for HIV/AIDS, and the way then that the epidemic settled in the Black community, especially with high numbers in Black women, right? We have to make sure that that doesn't happen with COVID-19. So I hope that everybody listening to me right now, I'm going to say it, gets the COVID vaccine, right? It is safe. It is life-saving. So get it. Anyway, that's not where I was going. What I was going is to say that sometimes if you're just focused on social determinants of health, you can make health disparities worse. So we must move into that 3rd dimension. We must understand the 3-dimensionality of the cliff and address the social determinants of equity or inequity, address racism and sexism and heterosexism and the like, because that's the way we're going to achieve social justice and eliminate health disparities. Now, usually I would stop right here and say, do you have any questions? But I have 3 frequently asked questions that I want to share with you right now. And then I want to take your questions on the cliff. And did this make any sense? And is it useful? And, whatever. So first of all, the first thing I want to say is Wayside Recovery Center, I am saying, is operating as an ambulance and a net and a fence, from what I understand of what you guys are doing. So you are doing all that. I do not know to the extent that you're also trying to move population away from the edge of the cliff, because usually that kind of work involves bridging with other sectors, because Wayside Recovery Center by itself cannot necessarily improve housing by itself. It needs to partner with housing, although I don't even know, you're probably providing some transitional housing, okay? My apologies for not going deeply enough into understanding everything that you do. But neighborhood housing, you need to partner, education and the like. So actually, once you get beyond the health sector, or, this cliff works for education and educational disparities, it works for housing and housing disparities. But once you get outside of your lane, then you must partner with others to be about moving the population away from the edge of the cliff. And the other thing is that when you want to start addressing the 3-dimensionality of the cliff, then you must be partnering with community and the people who are actually being pushed closer to the edge. So I want to say that wherever any of us is working or living, we have to recognize that we have to be concerned about all the other pieces. If you are trying to be the best ambulance driver you can be as a physician, you need to wonder, is there a net above me? And how strong is the net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating? And do I even do things the same way when I'm at different parts of the cliff? So whatever, if you're a net, if you're a fence, wherever, you need to think about all of these different levels. But furthermore, outside of your day job or your day role, we all need to be first concerned about the three-dimensionality of the cliff as citizens, and not just national citizens, as global citizens, as people concerned about the whole. The three-dimensionality of the cliff and addressing the disproportionate distribution of resources and populations must be our first focus, I would say, for all of us, even if that's not the first focus for us in our day jobs. But anyway, frequently asked questions. So people ask me, Dr. Jones, excuse me, but if this is a useful way of understanding different levels of health intervention, and if an ounce of prevention is worth a pound of cure, why are we spending so much money on ambulances at the bottom of the cliff? That's a very important question. I have, over the years, prepared 6 different answers to that. I'm going to share with you 2. The first answer that occurs to me is that it's perhaps the most cynical answer, or glib. There is a lot of money being made on ambulances at the bottom of the cliff by healthcare systems, healthcare providers, health insurance companies, pharmaceutical companies, medical device companies, and the like. But that, I don't think, is the core reason. I think the core reason is that we in this nation are so narrowly focused on the individual, we don't even recognize that there's a health problem until somebody has gone and fallen off the edge of the cliff, and we either catch them in our nets or scrape them off the bottom and speed them on to care. Here's another, so just to say on that, we don't even recognize the proximity of the population to the edge as a health problem. We are not even using aggregate measures of health, like income inequality or social cohesion or any of those. We don't even have a lot of aggregate measures of health. We are just focused on the individual one by one. Here's a second question. People ask it like, well, this is the sum of it. Why are greenies launching? Why are the greenies launching themselves over the edge of the cliff? Now, the way people have asked me this in the past is, why are those people eating so much fried chicken? Or why don't those people read to their children? Or why do those people do such and such? Or why don't they do the other? And that also reflects a narrow focus on the individual, because when we are narrowly focused on the individual, it makes systems and structures either invisible or seemingly irrelevant. So the systems and structures that have pushed the greenies to the edge and are keeping them there are invisible. But it also reflects the second of what, now I have 7 barriers to achieving health equity that I'll share with you much later. The second of those, the first is our narrow focus on the individual. The second is that we are ahistorical in this country. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. So we don't even ask or wonder or know that the greenies probably built all of the ambulances, nets, and fences. And then were moved to this other part of the cliff where they also built some more ambulances, nets, and fences for theirs and for themselves. And then it was burnt up in Greenwood and Tulsa. So we don't even understand the history of what we're looking at. Here is the third, hold on for a second. Here's the third question, frequently asked question. Most people don't even say out loud, but many of us act this out in our lives. And that is, this situation looks fine to me. What's the problem with a 3-dimensional cliff? And people act this in their lives, even if they don't say it. They say it we acted when we might leave a lovely home, drive through a distressed, disinvested, poisoned community, get to a lovely job, and not feel a strong sense of urgency to do something, to intervene urgently on that distressed, disinvested, polluted community that we just drove through. And that reflects a third barrier to achieving health equity, which is our myth of meritocracy. This story that goes something like this: if you work hard, you will make it. Now, I give you that most people who have made it have worked hard, although not everybody who's made it has worked hard. We have very prominent examples of that. But most people who have made it have worked hard. But there are many, many, many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by racism, sexism, heterosexism, capitalism, and the like, these social determinants of equity or inequity, these systems of structured inequity. And when we deny the existence or pertinence of racism and the others, we are blaming those who haven't made it for being lazy or stupid. We say, well, why don't the greenies just take a step back, without recognizing not only is there a system holding them there, but it is probably more slippery at that edge of the cliff where they are. We know for sure that it's higher up off the ground so that when they fall, the consequences are more dire. But anyway, enough of me talking. I'd like to pause now and take 1, 2, or maybe 3 of your questions or observations or anything that you want to share right now. So I hope that you've been putting it in the Q&A box. It's the best place, but even in the chat. And somebody is going to help me to see, are there any questions or comments there? And if they're not, somebody just say something you think I should add, or, a challenge or whatever.
So there are actually some comments in the chat that I can share with you. The people were really thought it was an amazing question when you were talking about how strong is the fence at the edge of that cliff. That was something that really caught people's attention. And also some comments around the prevention piece of this too, and the role that prevention will play. One of the attendees shared, talking about, yes, acting reactive rather than proactive keeps us at the cliff. And another panel or another attendee shared, just reminds me of all the methods of oppression consistently acting together. Another attendee shared, when assessing our response, I see the benefit of determining our fence, our net, and our response. And one item that I just wanted to share, sort of one of those aha moments that Oprah talks about that we have sometimes. You were talking about prevention, and then you started talking about the lack of data around social cohesion. And I was just thinking about that from the SUD field, the substance use disorder response field, because so much of the work that we do in terms of recovery is talking about the benefits and the needs and the place that connection within our community plays within recovery. So that was a really powerful statement that you made as well around the social cohesion piece, because that is so vital for long-term recovery.
Oh, well, thank you for that. Thank you for that observation. And I think that we're so comfortable, at the edge of the cliff, even thinking about fences, that sometimes our policy are still, when I think about, I have actually looked at people's strategic plans, or, the healthy people objectives on this thing and that thing, infant mortality. And I have sorted out people's actions or their strategies or their plans along the cliff. And very often, a lot of it is focused on ambulances at the bottom of the cliff, because that thank you, doctor, or thank you for saving me is very powerful. You know what I'm saying? And people don't understand how many people you saved with a strong fence. They further don't understand how many people you saved when you move people away from the edge of the cliff, because those people are not even feeling at risk, right? Furthermore, the oranges probably don't even understand their advantage relative to the greenies, because people rarely compare themselves to those who have less. They most often compare themselves to those who have more. And so the oranges that we see here are probably feeling needy compared to some oranges that are further away, or some reddies, or whatever is going on over there. So there's so many ways that this analogy can help us understand and help focus our work. But I really, really think that the way I use it when I'm talking to healthcare providers is, it is legitimate medical practice to be about anti-racism, right? Even if you are an ER doc, that your work legitimately includes anti-racism, because we have to, all of us in our day jobs and as well as citizens, address the three-dimensionality of the cliff. And when we get focused on whatever level we are and we don't even understand we're related to the others, then that hinders all of our work.
Yeah, and we've got a couple of questions that have come in now.
Okay.
Can you maybe share one other typical question that you tend to get around when you're talking about the cliff of good health?
So one thing, it's a question that's come up, it's kind of a theme. When we think about the United States and how much we spend on ambulances at the bottom of the cliff, and the fact that we're spending, I don't know, last time I looked, 17% of the gross domestic product of our whole, everything that we output, 17% on health care, right? And ambulances at the bottom of the cliff. And for that, we get, international rankings of in the 30s. We aren't number one. We're number one in spending, for sure, in all the nations in all the world. And we're 30 in outcomes. And so people ask me to talk about that and put that on the cliff. And so the way I think about that is that, first of all, social class, I think, is how far you are away from the edge of the cliff, right? That's social class. And there are, in our country, there's a strong relationship between social class and health outcomes. In other countries, there is a weaker relationship between social class and health outcomes. So somebody still could be, there's still a range of social classes, but when people fall, they don't fall as far. And that is because other nations either fill up the land so the cliff is not so steep, or put lots of mattresses, or however you want to think about it. And even though we're spending so much money on healthcare, we spend just a little bit on social services compared to other countries who spend less on healthcare, but a whole lot more on social services. And the total spending of ours on healthcare and social services is the same as total spending in other nations, but they're getting more bang for their buck because of how they're allocating it. They're not in mattresses. I mean, they're not in ambulances. They're either in mattresses or filling up the land, or, making it so it's not a cliff. So when we start talking about investment in social services, as the Biden administration is doing right now, as part of our infrastructure plan, indeed it is. Indeed it is. It is filling up the dirt so that the cliff is not as steep, and it is moving populations away from the edge of the cliff. But we have to understand, in the international context, our spending is way off.
Okay. So the next question, will you be discussing the 7 values targets for anti-racist action today?
Yes, I will. And I've realized, because of my lateness in getting on and all that, how much time do we have? 1 more hour? Is that what we have?
Yeah, we have another hour.
1 more hour. Okay,
Yeah.
so then we're going to be all right. And I'm not going to rush through, but we are going to stop answering questions right now. Please keep the other questions that have come in, but I want to get through everything and then have time. We'll have another pause for discussion. We can pick up some of those questions, and then we'll have time at the end. But yes, I am going to talk about that.
Wonderful. Sounds good.
Yes, thanks. So I'm going to start sharing again. And so I said the first part was just framing the work, like, why are we talking about racism? Why are we talking about racism as a public health crisis? Why are we talking about racism with Wayside Recovery Center? Why are we talking about racism at all? Now that we have decided we are going to talk about racism, because racism is creating this, it's one of the huge creators and maintainers of this 3-dimensional cliff. There are 4 key messages when we are naming racism. The first is that racism exists. And I have to say that's a key message, because there are many people in this country who are in staunch denial of the continued existence of racism. And all of these efforts to these anti-critical race theory efforts, and those people who are anti-critical race theory don't even know what critical race theory is, right? But they're anti-critical race theory and anti-talking about racism and acknowledging racism exists because it is going to make their little babies feel guilty or whatever. That's not what it's about. Racism does exist, so we need to be able to communicate clearly on that. The second of the 4 key messages is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that we can act to dismantle racism. So I am going to share an allegory, one of my teaching stories that's based on something that happened in my own real life that I call Dual Reality, a restaurant saga. And this allegory has as its moral, so spoiler alert, that racism exists. This was based on something that happened to me when I was a medical student, first year medical student, very diligent and studious. So on this Saturday, like on most Saturdays, I had awakened early. I was studying those in the books. It was already mid-afternoon. Some friends came over. Did they distract me from my studies? Oh no. We all got to studying long and hard, and now it's getting late and we're getting hungry and I have no food in the apartment, which was so typical of me. My friends were like, oh, okay, never mind, Camara, but we are hungry. Let's go into town and find something to eat. So we do. We walk into town, we find a restaurant, we walk in, we sit down, the menus are presented, we order our food, and the food is served. And here we are eating. So maybe not the story about racism that you thought I was going to tell in a restaurant, but hold on. As I sat there eating with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. And so now you're like, Dr. Jones, where'd you go to medical school? And what did the sign say? Oh, okay, well, what did the sign say? The sign said open. So now maybe I've lost you because like, how is an open sign a revelation about racism? Well, let me recap. Here we are sitting in the restaurant eating. I look across the room, I see a sign that says open. If I hadn't thought anything more about it, I would assume other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided sign, the two-sided nature of that sign, I recognized that the restaurant was now indeed closed. Because of the hour, but firmly closed. And that other hungry people, just a few feet away from me, but on the other side of that sign, would not be able to come and sit down, order their food and eat. And that is when I understood that racism structures open, closed signs in our society, that racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So for example, it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. In fact, it's difficult for all Americans to recognize our American privilege in the global context, although we are living at large right now with how much of the global supply of vaccine we have sequestered in this country. Those on the outside are fully aware that there's a two-sided sign going on because it proclaims close to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, but if you do, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Or maybe what you'll do is pass some food through the window. Or maybe you'll try to tear down that sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. So this is the story that I tell, especially, I mean, it's good for all of us. I hope you can remember the essence of this story and tell it on to family members and friends and coworkers and all of that, neighbors, because this is the story that I tell when I have just 5 or 6 minutes to convey to a group of people, especially a group of people whose whole life experience may have shouted that this is the land of equal opportunity, that yes, racism exists. It is structuring a two-sided or multi-sided sign in our society that is creating a dual or multifaceted reality. And actually, I have started a 3-hour conversation on 2 occasions, 3 hours each time, with the following question: how could people who are born inside the restaurant know something about the two-sided nature of that sign? And each time it was a 3-hour conversation, because there are many, many ways to know. I will say this: I am heartened that more people who were born inside the restaurant seem to have a sense now that there's something two-sided about that sign because of current events. More people who were born inside the restaurant who just a year ago might have been sitting inside eating and saying, what are those people outside saying? Black lives matter. Don't they know all lives matter? Are now actually affirming, yes, Black lives matter. More people who were born inside the restaurant are now saying the word racism and putting together the words structural racism or systemic racism. This is heartening to me. But I have a warning for all of us, as I had a warning before. It is important for us to name racism. It is important for us to say the whole word, because you have to name a problem so that you can start solving the problem. You have to put it on the agenda. But if we only name racism, if we only pass a resolution and then don't move on it, if we only put a statement on our websites, if we only tweet a tweet or put something on Facebook, 6 months from now, we may forget why we said that thing, because racism denial is so staunchly held in this nation, and it is so seductive that 6 months from now, we may fall back into what I describe as the sleepiness, the somnolence of racism denial. So we have to go beyond naming racism to action. We need to tear down the sign. And of course, racism is not just a sign, it's the sign, it's the door, it's the lock, it's a whole system. So we have to dismantle the lock, take the door off the hinges, because once we start acting, we will not forget why we are acting. So now I owe us all a definition of racism. When I say the word racism, I am clear that I am talking about a system. So I am not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. And yes, it can manifest in those ways. Racism can certainly show up in those ways, but in its essence, racism is a system of power. And a system of doing what? A system of doing two things: of structuring opportunity and assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race in this country. So just want to be clear, race is not biology. Race is not written in our genes. Race is written in our society. And the same socially assigned race that a person might notice on a street without asking you, excuse me, how do you self-identify? Or excuse me, where were you born? Where were your parents born? Or excuse me, may I have a little aliquot of your blood? I have a genetic hypothesis. It is that socially assigned race that is the substrate on which racism operates across the centuries and day to day, even in this time. So if race is the social interpretation of how one looks, racism is a system that uses that race to structure opportunity and assign value, and it has impacts. Now, when people first start understanding that racism, really exists, then they usually get to understanding that racism is unfairly disadvantaging some individuals and communities. But it shouldn't take any of us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people who are living as white, uncomfortable. I used to, when I get to this part of a presentation, almost apologize. I'd say, well, I'm not trying to make anybody uncomfortable. If you feel uncomfortable, shake it off, stay with me. I'll tell you some more stories. I don't apologize anymore in that way. What I say is, if acknowledging unearned white privilege, if acknowledging that racism is advantaging some individuals and communities makes you uncomfortable, you need to lean into that discomfort, because I have come to recognize that for all of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us do not recognize, and that is that racism saps the strength of the whole society through the waste of human resources. And that shows up in how, we don't vigorously invest in the full excellent education of all of our children, because the blinders of racism have made some people feel like, there's no genius in the barrios and the ghettos and the reservations. We can get along very well, thank you, without those kids, when of course there is genius in all of our communities. And if we were to only vigorously invest in all of that genius, we could be doing so much better as a nation or even as a world, right? This sapping the strength of the whole society happens when we are complacent with what I describe as the wholesale warehousing disproportionately of so many Black and brown men in our prison system and Indigenous people in our prison system, as if that did not separate us from human potential. And so this impact of racism, that it saps the strength of the whole society, is actually one of the three impacts that I think we need to lift up even more right now. We need to let people understand that yes, racism is unfairly disadvantaging some and unfairly advantaging others, but we need more media stories about how it is sapping the strength of the whole society, how the loss of Mr. George Floyd saps the strength of the whole society, because what genius did he bring, and what genius would he have poured into his child? And that Breonna Taylor, not only the work she was doing, but what she could do. Tamir Rice, baby Tamir Rice, his 12 years old and boom, playing with a toy gun and gone in seconds. So we need to understand that, plus the slow way that we sap the strength of our whole society through racism, the quick ways and the slow ways. We need to understand that as problems, more data collection on that, more media stories about that, more conversations around our dinner tables, so that more people feel a strong sense of urgency to dismantle this system and put in its place a system in which all people can know and develop to their full potentials. I just want to say one more thing on this slide, which is that many people in this country recognize that there are two states of being, but they describe them this way. They describe them as disadvantaged and normal. And the reason that many people think that there are two states of being, disadvantaged and normal, is that we are ahistorical. And people do not understand that their so-called normal is built up on a whole mountain of unfair advantage. So now I'm going to do a Marco Rubio and grab some water. Hold on. Let me just take a break for a sec. And then shift to that definition I gave of racism actually doesn't quite explain how does racism turn into differences in maternal mortality rates, the numbers of our mothers who are dying pregnancy-related deaths, which are 3 to 4 times Black as white and 8 times Indigenous as white, right? How does it turn into the disproportionate impact of COVID-19 on communities of color? How does it turn into the differences in substance use disorder treatments that we see, or deaths? Or how does it turn into the when it was a crack, crisis or whatever, it was it wasn't an epidemic that we needed to address with, Narcan and compassion and all of that. But when it's an opioid epidemic, and I'm not saying we needed to address all of it with compassion and Narcan and all. I'm not saying go back to the bad, but I'm saying, how is it that racism shows up in these differences, right? And so I've described 3 different levels of racism: institutionalized or structural, personally mediated, which some people call interpersonal, but I'm so clear that that racism is a system, and that this level is the system mediated through people, that I call it personally mediated, even though that's a tongue twister, and internalized. So let me define these levels of racism, give you examples of how they can impact health, and then illustrate them with my gardener's tale allegory. Now, I'm going to give you a warning. I'm going to spend a lot of time on this definition of institutionalized or structural racism, because this is a level that most people really don't fully understand. What is it? Well, first of all, it is the constellation of structures, policies, practices, norms, and values, which taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator, because it's been institutionalized in our laws and customs and background norms. This is the kind of racism that shows up as inherited disadvantage, or its reciprocal inherited advantage. We see structural racism in terms of, material conditions, as well as in terms of access to power. So examples include differential access by race to quality housing, or excellent educational opportunities, or equal employment opportunities, or even the same level of income at the same level of employment. And clearly those things impact health. Differential access to medical facilities, including physical access, financial access, linguistic access, scheduling, availability, access at all in terms of substance use, treatment programs and the like. A differential access to a clean environment, and the very well documented disproportionate placement of toxic dump sites and bus transfer stations in communities of color. And then with regard to access to power, that could be differential access to power as information, not just health information or true information about a vaccine or how do I get one, right? But information about our own histories. Differential access to power as resources, not just capital resources, but social networking resources, knowing somebody on the board, or actually being anchored in community, as Representative Richardson was saying before. And differential access to voice in government, voice in media, and the like. Now, I want to say that in the past, several times, when I've shared this slide, people have stopped me right about here and said, well, excuse me, Dr. Jones, but look at that first set of examples you provide: housing, education, employment, income. Dr. Jones, isn't that what we call social class? So why do you have that on a slide about racism? Are you talking about racism, or are you really, really talking about social class? This is a very important question. So I'm going to address it. And because many of you guys might have the same question in your minds and in your hearts. And so the first part of my answer is that it doesn't just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That's not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for example, for American Indians, the initial historical injustice was the taking of the land, and then the near genocide, and then moving survivors to reserved lands, reservations, and then in some instances, something good was found under one reservation. Oops, you got to pick the people up and move them somewhere else. And I'm horrified, as I'm sure you are, but people, indigenous people in this country have known this truth for a long time, when they started taking the children and sending them to boarding schools, and then all of these graves that we're finding in the Canadian boarding schools, and now we need to look in the US boarding schools, but the people knew, right? So, but that's for American Indians. What about people who lived in Mexico for centuries and never crossed the border, but the border crossed them and they find themselves in New Mexico and Texas and Arizona and California, where the great-great-great-grandchildren are still harassed and targeted and looked at with suspicion and disfavor. You know, the El Paso massacre, I think it's been now more than a year, but that kind of thing happens still. What about the Chinese laborers, at first brought here to build our railroads, but then with the Chinese Exclusion Act, unable by law to bring their families, unable by law to marry? What about the Japanese Americans interned during World War II, when the Italian Americans and the German Americans were not treated in that way? What about for people of African descent, the initial historical injustice being the kidnapping of West African people, our importation across the Atlantic with tremendous loss of life in the Middle Passage, and then what I described for the survivors and their progeny for generations and generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then people say, oh, Dr. Jones, there you go talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865. And here we are now in 2021. That makes that 156 years ago. Dr. Jones, all else being equal, don't you think the impacts of slavery would have washed out by now? But the key phrase, of course, is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are what I describe as present day contemporary structural factors that are perpetuating that and all of these other initial historical injustices. And these contemporary structural factors are part and parcel of structural or institutionalized racism. So when you ask me, am I talking about racism or am I really, really talking about social class? My response is that structural racism explains why we even see and association between social class and race in this country. This is a very important aha. Now, I want to respond to a few other things that have come at me over the years on this slide. One thing is, well, Dr. Jones, you're so concerned about race and racism. You don't care much about poor white people, do you? And that is not the case. I care deeply about poor white people, poor Black people, poor Indigenous people, poor Latinx, Hispanic people, poor Asian people, poor Native Hawaiian, other Pacific Islander people, poor all kind of people. It's not any kind of game to be poor, right? And we need very vigorous anti-poverty interventions. Indeed, we do. In fact, if I had a magic wand today, I would eliminate poverty. If I had a magic wand that I could go ding, ding, and not only eliminate poverty, but go all the way and eliminate income inequality, I would go that far as well. And actually, the child tax credit is a good start at eliminating child poverty. At least it's projected to eliminate half of child poverty, 1/3 of poverty overall, but we need to go beyond. But let me tell you this, give me that magic wand, I will use it immediately. But if I do that without addressing the background structures, policies, practices, norms, and values that are the mechanisms of structural racism, even if I equalized income today across all of us within one generation, if I didn't address the mechanisms of structural racism, we would start to see a disparity, a widening in inequality in income by race again. This is not either an either or proposition, anti-poverty versus anti-racism interventions. This is a both and. And I want to end on this slide by saying that structural racism can show up through acts of doing, acts of commission, as well as acts of not doing, acts of omission. And very, very often it shows up as lack of action, inaction in the face of need. So I told you, I already warned you, I was going to spend a lot of time on that because we need to understand all that. The other two levels of racism I'll go through more quickly, but personally mediated racism I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. This is what most people think of when they hear the word racism. Somebody did something to somebody. It includes the different idea, the prejudice, and then the different action, the discrimination. So clearly you guys have lived through police brutality in spades, as we have all over the nation, but oh my God. So yeah, that's, you know, a police officer assumes that what you have, that your cell phone is a gun, or that you are a menace to them, or whatever it is, right? So that has impact not only on the lives that are lost, or like with Jacob Blake, permanently injured, but on the families for sure, but also on whole communities who are just bracing ourselves for the next occurrence, because for the most part, it's very limited accountability. So we're happy that there was accountability with the, you know, Derek Chauvin and the murder of Mr. George Floyd. We're happy, but that's not justice, and we need more accountability, but what we really need is justice, right? And we need to stop the deaths. Physician disrespect, which can be as subtle, let me tell you, as a physician not giving a patient the full range of treatment options because a physician figures, well, that patient wouldn't understand, wouldn't comply, couldn't afford, or whatever it is they assume. And that may happen to some of you all who are listening to me right now. Or it could be quite blatant, like sterilization abuse, which has had many, many iterations in our nation's history. Shopkeeper vigilance, being followed around in stores, or waiter indifference, not getting quick, respectful treatment, which are just two manifestations of what some people call everyday racism, the microaggressions, the subtle communication of disrespect that might be related to elevated blood pressures in communities of color, blood pressures that don't even go down at night. And then teacher devaluation, very important. If a teacher looks at a young child and thinks that child can't learn and puts them off in the attention deficit disorder track, that child may never even know their full potential, much less have the opportunity to develop to their full potential. Like structural racism, this level of racism can occur through acts of doing as well as acts of not doing, but even more important is to recognize that personally mediated racism can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. And we need to separate intent from the law. There's so much of our civil rights stuff that has intent built into it. Intent does not matter. We need to be looking at the impact. The last level of racism, internalized racism, I'm defining here from the point of view of members of stigmatized races as acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. Now, I do recognize, as many of my colleagues in anti-racism have said to me, Camara, what about the internalized sense of entitlement that many white people walk around with? Isn't that also internalized racism? Yes, I agree. But I don't have it on this slide because, first of all, I don't know how an internalized sense of entitlement really shows up as bad health outcomes, except I have recognized that maybe a sense of entitlement thwarted may be at the base of what some people are describing as the diseases of despair in white populations, the suicides and the opioid epidemic and the like. But here on this slide, I am speaking from the point of view of stigmatized members of stigmatized races, where internalized racism shows up as self-devaluation, feeling maybe I'm really not as good as. Maybe I shouldn't try to graduate from high school or go to that college or try to get that job or live in that neighborhood. It shows up as the white man's ice is colder syndrome, where that phraseology I learned from my parents. And in that time, and probably their parents' time and before, and even today, what it means is there are people of color, so say I'm Black, who, if I need a lawyer, I might seek out a white lawyer over a Black lawyer. Or if I'm sick, I might prefer the white doctor over the Black doctor if I could find a Black doctor. Or if my lemonade were warm, I might go way down the street to get the white man's ice over the Black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. It turns into resignation, helplessness, hopelessness, which turns into a lot of self-destructive health behaviors. And really, it is basically about members of stigmatized races accepting the limitations to our own full humanity of the box into which we've been placed. So that when we hear young high school students of color, and one in the friend group is trying to be the valedictorian of the high school, and the others are teasing her or him by saying, well, you know, so-and-so is just trying to be white. We need to stop that. We need to interrupt that, right? We need to shut that down, because since when did white people claim exclusive access to excellence? They did not. So now I'm going to share another allegory that's going to bookend this part of our conversation. This is my Gardener's Tale allegory. Some of you all may be familiar with it from before. If you are, as I tell it, I want you to listen with different ears to the nuances of the storytelling so that you can confidently tell it on. But for the others who haven't heard this before, just sit back and relax. And I'm going to stop sharing now because I'm going to be using my hands a lot. So this was based on something that also happened in my own real life. So let me tell you what I saw with my own real eyes, and then we're going to make it a story about racism. So my husband and I, newly married about a year, moved down to Baltimore so I could finish my PhD at Hopkins. And we bought our first freestanding house, cute little house with a big wraparound porch with flower boxes dotted all over the porch. Now we bought this house in October, which really was not the time to plant in Baltimore, so we waited. But when spring came, my husband, who loves to garden, he ran out with our marigold seeds, going to decorate our cute little house. And then he came right back in and he said, Camara, some of these boxes have dirt in them, but some of the boxes are empty. So I need to go to the gardening store. So he does. He goes to the gardening store and he comes back hauling big old bags of potting soil, right? And then we fill up the empty boxes with that potting soil. And then we take equal numbers of the marigold seeds and put them in equal numbers in all the boxes. And then we water all of the boxes equally. And by this time, I, who am not the gardener in the family, I'm exhausted, right? So I figure I'm just going to sit back and be delighted. Well, about 3 weeks later, when I'm walking out of my front door onto my porch, I finally pay attention to these flower boxes. And what I saw made me literally stop in my tracks, because what I saw made me think that we had planted completely different species in some boxes versus others, because some of the boxes were full of plants and they were tall, vigorous looking plants. And some of the boxes just had a few plants in them and they were kind of scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that every single seed planted in the rich, fertile soil had sprouted. The strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. But that old soil that we had found there turned out to be poor, rocky soil. So the weak seed planted in the poor, rocky soil just died. But even the strong seed in the poor, rocky soil had to struggle to make it just to a middling height. And maybe some of you guys are nodding now because maybe your gardeners, and maybe you've composted half of your garden, and maybe you've seen this image with your own real eyes. And the image, of course, is about the importance of the soil, the importance of the environment. But now I'm going to take this image and I'm going to make it a story about racism by introducing a gardener. So now we have a gardener who has two flower boxes, one which she knows to have rich, fertile soil, one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms and some of the seed is going to produce red blossoms. And the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in the rich, fertile soil, pink seed in the poor, rocky soil. 3 weeks later in her flower boxes, she sees what I saw in mine. In that rich, fertile soil, all the red seed sprouts, strong red seed grows tall and vigorous, even the weak red seed makes it halfway up. In that poor, rocky soil, the weak pink seed dies and the poor pink seed has to struggle just to make it to a middling height. And then in those flower boxes, those flowers go to seed. And the next year, same thing happens. And then those flowers go to seed. And year after year after year after year after year after year, the same thing happens. And finally, about 10 years later, the gardener's looking at her flower boxes and she says, you know, I was right to prefer red over pink. So now we're going to interrupt the story and say that the first part of this story illustrates how structural or institutionalized racism works, where you had the initial historical injustice of the separation of the seed into the two types of soil. You had the contemporary structural factors of the flower boxes keeping the soil separate. And then through lack of action, inaction in the face of need, perpetuation of the inequity. But let's pick this story back up to say, well, where is personally mediated racism in this garden? Well, the gardener is looking over the red flowers thinking, oh, red is so beautiful. And then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or she may notice that a pink seed has blown into the rich, fertile soil. So she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in this garden? Well, the red flowers are just living their lives, enjoying being red. Many of them not acknowledging or perhaps not even understanding that they're benefiting from enriched soil. Pink flowers are looking over at red thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees minding their own business, collecting nectar, but pollinating at the same time. So here comes a bee into one of the pink flowers, and then to another pink flower, and to this pink flower. And this flower's like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red. Because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is an important intervention. But if that's all we do, it's not going to change the situation in which the pink flowers find themselves. So you say, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener, or better yet, let's have a workplace multicultural workshop for the gardener. So we do, that's all good. So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which the pink flowers find themselves. If we really want to set things right in this garden, we must address the structural racism, which means that we have to either break down the boxes and mix up the soil. Or if you want to keep separate boxes, I guess that's all right too, although it does make it easier for that same gardener to keep segregating resources going forward. But at least in that moment, if you want to keep separate boxes, it means we have to enrich the poor rocky soil until it is as rich as the rich fertile soil. And when we do, the pink flowers will flourish to be looking beautiful, grand and glorious. And in fact, you know, that seed has been selected for survival and strength. So they might even look a little bit better than the red. I used to say that all the time, but I don't say it all the time now because that's part of the red flowers fear. But anyway, so I didn't say it if that makes you uncomfortable, or maybe lean in. But in that intervention on the structural racism where the pink flowers are now looking beautiful, just as beautiful as the red, that intervention will also address the internalized racism, because pink will no longer be looking over at red thinking red is better or wanting to be red. And in that intervention on the structural, we may also address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful would be less likely to have that kind of attitude. So this story has been to illustrate 3 levels of racism: structural or institutionalized, personally mediated, and internalized, and to strongly suggest that if we want to set things right in the garden, we need to at least address the structural racism. Good to address all the levels at the same time, but at least address the structural. And when we do, the other levels may take care of themselves. But there's one more question that I haven't raised yet, which is, who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, and control of resources, which are actually the elements of self-determination. Who is the gardener? Well, in the US context, the government is a huge part of the gardener, but not the only part. Media, foundations, corporations, health systems, communities to the extent that they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red, that's why she prefers red over pink. And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. So now the question arises, what do we do about the gardener? Do we make the gardener striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Many questions can arise out of this. And before I open it for your questions, this is like a 1-minute heads up, I want to share with you 2 other questions that are now my frequently asked or favorite questions. The first was asked of me maybe 20 years ago. It was, excuse me, Dr. Jones, but why should the red flowers share their soil? When I heard that question, I loved the question because it showed me the power of this story to start conversations about racism that might be otherwise difficult if we were talking about racism between you and me. My answer to that question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers. It belongs to the whole garden. Here's the second question. What if that's not the original gardener that we're looking at right there? What if that's the gardener's great-great-great-great-grandchild? Here we are. And the great-great-great-great-grandchild has never even seen anything different, has always seen the flowers looking like that, may not even think there's a problem to be solved. So very quickly in 3 steps. First, we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. We have to put it on our urgent action agenda, not even the eventual action agenda. The second thing is, okay, now that we have it on the agenda, what are we going to do? Well, we have to make those flower boxes transparent. We need to be talking about the differences in the quality of the soil. And then the third step is, as we make those flower boxes transparent, we also need to make sure that everybody understands that the pink seed did not just go launch themselves into that poor rocky soil. So we must talk about history, and we must especially talk about how the gardener's initial preference for red over pink set up the whole situation, and how the continued preference for red over pink sustains it, keeps it going. So that preference for red over pink, some people might describe as cultural racism. In our context in the United States, it is clearly white supremacist ideology. We must address that, because if we do not, even if we're able to compel that red gardener to enrich the poor rocky soil today until it was as rich as the rich fertile soil today, if she continues to prefer red over pink, she'll continue to privilege red over pink going forward. So for many years, my gardener's tale was just about the quality of the soil, until one day in the telling of it, I recognized this other aspect. And so we need to address both the opportunity structures and the value assignment. Racism does both, right? We need to address both if we're going to set things right in this garden. So now I am going to pause for another discussion and stop sharing and take your questions.
Okay, so a couple of comments that have come in since you have talked about your last allegory. Someone shared how their internalized white privilege may lead to negative health outcomes by not getting the vaccine, because I will assume that I will have the chance to get one whenever I want.
Oh, I love it. I love it.
Yes.
Okay.
And someone said, you made the comment about white people cannot claim exclusive access to excellence. Love that. Someone shared, we need more flowers, more bees, and more honey. And we had a couple of questions that I carried over from before that seem timely right now. One, you were just talking a little bit about the history piece. And this question is, how does generational trauma factor into these analogies. And I think this applies to both the cliff and the analogy, the gardener's tale as well.
Okay, and that's a very important question. And it does, of course, but I don't think that generational trauma is forever, ever. Like, we already know that there's, the epigenetic stuff and all, but I think that's not forever, ever either. So the way I think about it is that we have poor rocky soil, and we have the strong pink seed. The weak pink seed has died. So now we've already selected for strength and resilience, but we selected in greatness, right? But that strong pink seed only makes it up to a middling height. At the moment that we enrich that poor rocky soil until it's as rich as the rich fertile soil, the pink seed that's already sprouted and is a flower may make it up another 1/4 inch. It's not until the seed for that flower falls into the rich fertile soil that we will really see the impact of our interventions. So the intergenerational trauma clearly affects those of us who are already manifest in the world. But I think if we really have rich fertile soil, it will only take 1 generation, 2 at the max, for us to see our children flourish, right? So yes, there's the historical trauma. It's real. There's the epigenetic changes that we see around our genes. These are real things. There's the post-traumatic slave syndrome for Black folks, the historical trauma, indigenous folks, like all of this stuff is like real, real, real. The internalized racism is real, but it's not that we're born with these things or born less than, and all we have to do is change the soil, change the situation, and change the value systems around that. So we need to become part of the power, whatever, if we're going to change the value systems. Value systems change when the people change at the decision-making tables. The agendas change when the people change. So if we're trying to make it to somebody else's table or set our own tables, we need to figure out what we're going to do. But we need to have self-determination. And we need to invest in all of us. Clearly, the current investment strategies in our nation and the current way that the nation proceeds without recognizing that racism is sapping the strength of the whole society is that people of color have been so devalued that people don't even recognize what they're missing, right? And I don't have the perfect story for that. I'm still looking for the perfect story to clearly communicate. I can add to the gardener's tale, for example, and say, well, that garden will never get a prize from the garden committee that goes down the block, right? And so they'll never get more money or more fertilizer or more anything because of that garden just doesn't look good, even though our gardener thinks it looks fine. And our gardener actually doesn't want to compare themselves to other because they think that we have the greatest garden in the world. They don't even look at other nations or other gardens in the neighborhood. So, but we don't recognize the loss. We don't recognize the loss of all the genius and all of the potential and the love and the creativity and the leadership and all of that stuff. We really just don't recognize it. And so it's going to be hard, but this is our challenge, and we're up to it. There's so many people. So anyway, there we are. I went far from that historical trauma just to say it's real, but it's not permanent. All we have to do is change our life conditions. We have to change the resources, the opportunity structures, and boom. Oh, I'll just say one more thing. We have to change the opportunity structures. The boom is not as sudden. We have to change the opportunity structures, and we have to interrupt the intergenerational transmission of racism denial. So we might have to let those people who are racism deniers die off. And what we need to do is interrupt their ability to transfer that racism denial to their children, which is why I intend, for one, to write I have 6 or 7 allegories out in the public, but about 30 or 40 on my computer, write each of my allegories as a separate children's book so we can have a library of children's books that can equip parents who don't know how to talk to their children about racism because their parents never talked to them, as well as teachers, librarians, all of us can have a resource. So we need to interrupt the intergenerational transmission of racism denial and invest massively in our, especially communities of color, and invest around all children, because there's no such thing as my children or your children. All children are our children. So invest around children and their families. And then I think that's the prescription.
Well, and I will say I'm really excited to hear about the children's books. I will be among the first in line to get those when they come out. But I'm cognizant of time here as well, And I know that there's a new allegory that I'm sure people want to hear. And I do have questions. So do you maybe want to go to the allegory, and then I'll continue to keep comments and questions going?
Yes, please. I know I talk long. I really do. I talk deeply into each slide too. I'm sorry, but here we go. We're going to get back, and I'm going to share that new allegory, and then sort of race through some of the other stuff. Okay. So this is my newest allegory that I call Cement Dust in Our Lungs. And the moral of this story, I'll already tell you, is that we have to not only recognize that racism is a system, but we need to address racism as a system. Our interventions need to be addressed at the system. So when I say cement dust here, think cement dust and also think racism. So imagine that there's a cement factory spewing cement dust, and the dust just fills the air. And if any of us are anywhere around this dust and this factory for any amount of time, we're going to get cement dust in our lungs. And the cement dust in our lungs is problematic for all of us. We don't all recognize that we have cement dust in our lungs, but it actually, whether we recognize it or not, is problematic for all of us. And the cement dust in my lungs might make me feel that I'm less than, so it might be kind of internalized racism, cement dust, whereas the cement dust in somebody else's lungs might make him feel that he can, with equanimity, crush the life out of another human being with his knee for 9 minutes and 29 seconds. So that might be personally mediated cement dust effects. But for all of us, it's problematic. So the question is, what are we going to do? Well, do we start out focusing on the individual? Let me show you one strategy that I don't recommend, but let's say that we had a screening tool and we screened people, a machine, and then, oh, if we find too much racism and, I'm sorry, too much cement dust in your lungs, bam, bam, some alarm goes off. I don't think that this is a useful strategy. First of all, because what are we going to do with those people? But also, this is what makes people afraid to even say the word racism, because they think when you say the word racism, or they ventured or they hear it, that somebody is trying to divide the room up into who's racist and who's not, or peer deeply into their soul to ask exactly how racist are you. So this is not the idea. This is not what we're doing. We're not trying to identify individual races, but maybe there's somebody at the individual level who recognizes they have cement dust in their lungs, and they want to, we set up cleansing spots so that they can go and get it out of their lungs, right? And so this might be our trainings or whatever, and people come out, and they're good as new, but they come into the same cloud and the cement dust reaccumulates, which we see with our short-term interventions, right, at the individual level. So maybe we shouldn't focus on the individual. Maybe what we need to do is acknowledge that we're living in this cloud of cement dust. Name the racism, name the dust. So if I'm here and all of a sudden I recognize, yeah, I have cement dust in my lungs, but it's not because I was born that way. It's because I'm living in a cloud of cement dust. Maybe I'll choose to put on a gas mask, right? Recognizing that this gas mask, which is the start of my individual anti-racism journey, is going to keep new dust from coming into my lungs, but it's actually not even going to extract the dust out of my lungs that's already there. But it's a good thing, right? It's filtering all this stuff. I can see more clearly now, actually. And also when I see myself reflected in a glass or a mirror, I keep remembering, yes, I am living in a thing of cement dust. And when you all see me, you're going to ask me, Dr. Jones, why are you wearing a gas mask? And I'm going to say, we're in this cloud of racism, a cloud of cement dust. And so maybe more and more of you all are going to don gas masks. Is that the answer though? That we're going to have everybody trying to put on a gas mask, make little baby gas masks and old people gas masks and the like? I think that is insufficient. What we really need to do is dismantle the factory. So especially those of us who've already started our individual anti-cement dust journeys, we need to move into action and try to get a good look at the factory, which has been shrouded in the dust. We can't even see it. And we need to ask, how is this factory operating here? How is racism operating here? And then we need to organize and strategize to act to dismantle the factory and put in its place a system in which all people can know and develop their full potentials. So this story is to illustrate that not only do we have to understand that it's a system, we need to address it as a system if we want to set things right. Now, I raised the question, how is racism operating here as an important, first of all, that's one of the 3 tasks that I identified at the very beginning when I talked about the 3 tasks of my national campaign against racism. We're just getting there. But that's a legitimate question, because racism is not just a cloud or a miasma that we can't get a handle on. It is a system with identifiable and addressable mechanisms, which are in our structures, policies, practices, norms, and values, which are actually the different elements of decision-making, where structures are the who, what, when, and where of decision-making, who's at the table and who's not, what's on the agenda and what's not. And whenever you find yourself at a decision-making table or set one, I charge you henceforth to have your first job be to look around and say, well, who is not here, who has an interest in this proceeding? And then your job is not just to represent their interest, although you might have to do that in the very short term, but your job is to create space, to find them a way to the table. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. And I recommend that we take this question, how is racism operating here with us everywhere? How is it operating in my child's daycare? How is it operating within this center, in my workplace, in this community, and the like? Here's an example of using this question, how is racism operating here, to examine police killings of unarmed Black and brown men and women. And we ask this question so we can identify levers for intervention, targets for action. So with regard to structures, the absence of civilian review boards to be, overseeing police departments is a structure that could be a useful target for action. The use of grand juries to indict police officers in most cases. So it's not enough that the police officer shot the gun or had the knee or whatever, and the person is dead, and you can, bring a charge of murder. No, it has to go through a whole different process. Or the adoption by many states in their legislation of elements of the Law Enforcement Officers' Bill of Rights, which interferes with accountability. And a police officer can be found liable in one department and go someplace else, and all of that, all of the different elements of that. Practices of over-policing of communities of color, which results in more accidental interaction. Practices of no-knock warrants or chokeholds or carotid holds, which some departments are now banning. The norms of the blue code of silence. If I'm a police officer and I see somebody else, another officer doing something wrong, I just didn't see anything. I actually understand that some departments are mandating now, if you see another officer doing something wrong, you are mandated to intervene. And the view of Black men and other men as inherently threatening. So if you say, oh, I felt my life was in danger, that's why I killed him, people say, oh yeah, well, he was a big Black man. Got you, right? And then the values of the devaluation and indeed dehumanization of people of color. So it doesn't even seem, I saw this video of a white man who was struggling with police, and he actually got one of the police officers' guns and he shot it, and they continued to struggle with him. They didn't kill him. And in the end, all he got was like a fine or something. That if that person had been a Black or brown or indigenous person, they would have been dead. Now, the definition I gave for racism can actually be generalized to be a definition of any system of structured inequity. So what is sexism, for example? That is a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. And I recognize there are many axes of inequity operating in our society today, intersecting in communities and in individuals. And all of these are at least risk markers for how opportunity is structured and value is assigned, even as a subset of them are also risk factors in the progression to disease. So I've been talking about race and racism for a very long time now. People say, well, Camara, why did you say this now at the end, that you recognize all this other stuff is going on? And why do you focus your work on race as the axis of inequity and racism as a system when you recognize all this other going on? My answer is that racism is foundational in our nation's history, and yet many people are in staunch denial of its continued existence and of its profoundly negative impacts on the health and well-being of the nation. So I actually believe that all of us should at least be actively anti-racism. And I don't say actively anti-racist because people think racist, you're talking about people, you're talking about me. No, we're talking about a system. So I think we should all be actively anti-racism, even as we engage in these other struggles. And to the extent that we're able to dismantle the mechanisms of racism, the other struggles will benefit as well. Now, I want to very quickly give you my three-part definition of health equity so I can get to the 7 values targets, the 7 barriers to achieving health equity. 3 parts of definition. What is it? How do we get there? How is it related to health disparities? I define health equity as assurance of the conditions for optimal health for all people. Healthy People 2020 defined health equity as attainment of the highest level of health for all people. I helped write that definition. It's a good definition. I agree that that's our goal, but I don't think, and further, I'm thinking of it further, I don't think that that health equity is an outcome, attainment of the highest level of health for all people. Because what if we hit that last Sunday? Are we done? No, health equity is a process. Which process? Assurance, which is actually one of the 3 core functions of public health identified by the Institute of Medicine, along with assessment and policy development. And assurance, of course, is a governmental plus function. Assurance of what? The conditions for optimal health, the social determinants of health, for whom? For all people. That's what makes it equity. How do we get there? Achieving health equity requires at least these 3 things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. How are health disparities related to health equity? Health disparities will be eliminated when health equity is achieved. Health disparities are the differences in outcomes, the numbers of different colored bodies at the bottom of the cliff, the differences in the height and vigor of the pink and red flowers. Health equity is all that opportunity structure stuff before. And if you're wondering, am I doing something that gets me toward achieving health equity? Are you valuing all individuals and populations equally? Well, how do I know? Well, think about how you might value your children or your nieces and nephews, right? You would protect them, invest in them, celebrate them, invite their input, all of that. Are we doing that equally for all individuals and communities? Am I recognizing and rectifying historical injustices? Do you even know the history of the place where you are and the work that you're doing and all? So we need to learn our histories, even of workplaces and of communities and the housing stuff going on, and of cities and states and the nation and the world. And then when we see historical injustices, are we working to rectify them? Reparations, that's not a bad word. That's a necessary step. And then providing resources according to need has 2 steps. Agreeing on a metric of need, which might be the number of people dying from COVID-19 per 100,000 population in that group. So, right, and in all these other groups. But then when you get resources, you also need a political spine to distribute those resources according to need, right? So instead of letting the vaccines go to first come, first serve, no, the vaccines should go to the highest, most impacted communities and the like. I could stay, as you know, a long time on a lot of slides. I won't. And because somebody asked me specifically for this, and I'm 2 minutes over already. These things that I'm about to share with you, I used to call the 7 societal or cultural barriers to achieving health equity. And now I describe them as the 7 values targets for anti-racism action, or even more, I describe them as the 7 social delusions that undergird the intergenerational transmission of racism denial. Here they are. The first 3 I've already talked about with regard to the cliff. Our narrow focus on the individual, which not only makes systems and structures invisible or irrelevant, it makes our sense of self-interest very narrowly defined. So if you're not interested, if you don't think of your aunts and uncles as self, you certainly don't think of those people across town as self. It limits our sense of interdependence. There, but for the grace of God, go I, we are all in this together. I am my brothers and sisters' keeper. And it limits our sense of power because we think, well, what can I do about racism? When the more useful question is, what can we do about racism? And we need to think in terms of collective efficacy. The second, the ahistorical stance that we act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. I've already talked about that. But if you are ahistorical and then you're born and you see things a certain way, you think they've always been that way and you think they will always stay that way. So it even limits our idea of how we make change. The third, the myth of meritocracy. If you work hard, you'll make it. We talked about that and how, yes, most people who've made it worked harder, but there are many other people working just as hard or harder who will never make it because of an uneven playing field that has been structured and is being perpetuated by racism, sexism, heterosexism, capitalism, all of these systems of structured inequity. When we deny these systems, we not only blame the people, right, but we don't even understand what we need to do. And there are many ways to deny racism. A well-practiced way is to say racism doesn't exist. But we also deny racism when we're all about diversity, equity, inclusion, belonging, disparities, disproportionalities, cultural competence, cultural humility, structural competence, race, all of these things, and we never say the word racism. Because if we do not say the word racism in the context of our national widespread racism denial, we are complicit with that denial. We need to say the whole word racism, get the ism out, because that's the structure piece. Our myth of a zero-sum game, if you gain, I lose, which fosters competition over cooperation, it masks the cost of inequity that racism and these other systems are sapping the strength of the whole society. And it hinders efforts to grow the pie. It's like I'm sitting at a potluck dinner, I see you coming, I don't want you anywhere near this table because I think that you're just going to come and eat up all the food. I don't even recognize that you're bringing all kinds of cakes and pies and roasts and salads and fruits with you, because my devaluation of you doesn't even allow me to see that you could be enhancing our table and I won't let you come because I'm fearing that you're going to eat it all up. Our limited future orientation. There are two things that each of us can touch right now that will hopefully survive us: the children and the planet. In this country, we have a disregard for the children and a usurious relationship with the planet. We do not, like many American Indian nations do, have a 7 generations hence approach to our decision-making, 100-year, projection into the future on our policies and their impact. Nor are we like the Maasai people in East Africa, who I understand when they greet one another, don't say, hey, how you doing? But they ask the question, how are the children? Hoping to get the answer, all the children are well. We don't even ask, how are the children in this country? And if we did, we wouldn't get the answer, all the children are well. The 6th of these 7 is our myth of American exceptionalism. I put American in quotes because we say American as if that's the United States, but of course Canada and Mexico and all the countries in Central and South America are also American. But this myth of US exceptionalism, that we're so special, so different, so ordained by God that the usual rules shouldn't apply to us, that we are so entitled to all of this vaccine that we have sucked up into our nation. And it makes us disinterested in learning from others. So if we had only paid a little attention to how many other nations were handling the COVID-19 pandemic, hundreds of thousands of lives would have been saved. And finally, the 7th is actually the first of these barriers to achieving health equity: white supremacist ideology. I put it 7th so that people can keep listening to me until I get there. But I recognize that many people might be thinking I'm saying this as a lightning rod term. I am not. White supremacist ideology is the simple description of a false idea of a hierarchy of human valuation by race. There is no such hierarchy, with a false notion that there is a hierarchy and that white people would be at the top of it as the ideal or the norm. But this false idea gives many people living as white a sense of entitlement. It results in the devaluation and dehumanization of people of color and fear at the browning of America that underlies a lot of our political divide today. So what can we do today? Going back to that image of the dual reality, we need to actively look for evidence of two-sided signs. Is there something differential going on by indigenous status, by race, by language, by immigration status, by zip code, by religion, by urban, rural? Is there something differential going on, not only in terms of outcomes, but also in terms of opportunity structures? And we cannot feel complacent while looking up and saying, it looks open to me. We need to actively look for evidence of two-sided signs. We need to burst through our bubbles of experience to experience our common humanity. Each of us lives in a bubble of experience. Our children, if we have them, our community, our jobs, if we have them, our, sororities, fraternities, faith communities, if we have them, all that stuff around us. Some of our bubbles are big with thin soap bubble boundaries. Some of the bubbles are smaller with thicker plexiglass bubble boundaries. Some of our bubbles are tinted. Some of our bubbles are polarized. But whatever kind of bubble each of us lives in, most often we do not know that just across town, there are people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to create opportunities for bubble bursting at the individual and institutional level so that we can experience our common humanity or across town, so we can start building common cause. We need to be interested in the stories of others, believe the stories of others, and then join in the stories of others. I am heartened that we're doing that now, but sometimes the believing the stories of others still depends on a cell phone video or some, an officer's body cam footage. We need to just be interested, believe, and join in because we are all human. We need to develop a sensitivity to see the absence of who is not at the table, what is not on the agenda, what policies are not in place that have put in place could move us toward justice. And we need to reveal inaction in the face of need, because lack of action in the face of need is how structural racism very often manifests these days. But all the power is not just on the part of those inside the restaurant. Those of us on the outside need to know our power, need to recognize that action is power, and especially that collective action is power. Now, I told you that I would normally stop there, but I do want to just run through this primer unless you tell me. You can tell me in voice not to do this. This will take 1 minute. Can I carry on even though we're over time, Representative Richardson?
Yes, please do.
Okay. So there were 3 tasks for our national campaign against racism: to name racism, ask how is racism operating here, and organize and strategize to act. There were 3 dimensions that I illustrated along the cliff: curative and preventive services at the edge of the cliff on the line, addressing social determinants of health on the plane, and addressing social determinants of equity, acknowledging and addressing the 3-dimensionality of the cliff. 4 key messages when naming racism: that racism exists, that racism is a system, racism saps the strength of the whole society, and that we can act to dismantle racism. I illustrated 3 levels of racism with my Gartner's Tale allegory: institutionalized or structural, personally mediated, and internalized. I gave you 3 principles for achieving health equity: that we need to value all individuals and populations equally, recognize and rectify historical injustices, and provide resources according to need. I described 7 barriers to achieving health equity: our narrow focus on the individual, the ahistorical stance, and the myth of meritocracy, the myth of a zero-sum game, our limited future orientation, the myth of American exceptionalism, and white supremacist ideology. I just gave you right now 6 actions that we need to take today, thinking about that dual reality image. We need to look for evidence of 2-sided signs, burst through our bubbles to experience our common humanity, be interested, believe, and join in the stories of others, see the absence of, reveal inaction in the face of need. That is how structural racism very often shows up these days, and know that collective action is power. And finally, I didn't give you these, but this is my final gift to you, my charge to you. I call them my 4 BCs. Be courageous. Speak your truth, embrace challenge, be unafraid of controversy, live at the edge of your comfort, because the edge of our comfort is our growing edge. Be curious, ask why, and then ask why again and why again, because these serial whys will take us from kind of superficial individual explanations to root causes. Be collective, care about the whole, and bring your whole self to the collective, your insights and your finances and your organizing ability and your joy. And finally, build community. Talk to strangers, connect people one to another, and go across town and stay a while. So sorry I've gone over, and I really hope that some of you will stay for further discussion, because I'm here. I have nothing else to do for the next bit. And so thank you for allowing this amount of time, and I hope we can still talk.
Presentation. You are amazing as always.